Want to implement this at a later level?
No, sir, this we have done it in during this 1.5 years.
Yeah, you have done it.
Yes.
So this is your model which you have created, is it?
Yes.
So what are the differences and similarities in this model and which is already existing by the government of India?
Sir, like already VHSNCs were initiated during the 2005. All this implementation research, what they try to do, they don't want to create a new model. They just wanted to create ideas from grassroots, which idea can fast track this outcome.
So you mean this should be a restructuring of the model. Thank you.
Thank you, ma'am. We'll go ahead to the next presentation, that is from Dr. Nilesh M. Engel. He will be presenting on clinical study of Prakriti-based academic stress of school children in tribal area with special emphasis on anti-stress effect of ashwagandha granules.
Yeah, sir, it's 7 plus.
Om Dhanvantare Namah. Respected chairpersons sitting over here, all the respected dignitaries in front of me. Myself, Dr. Nilesh Emigre, I am from HUTM's Vidarbha Ayurveda Mahavidyalaya Amravati, and presenting in front of you my research work, clinical study on Prakriti-based academic stress of school children in tribal area with special emphasis on anti-stress effect of ashwagandha granules. In Ayurveda, there is one verse which states that Samadosha Samagvishcha Samadhatu Malakriya Prasanna Atpendriya Manaha Swasta Ityabhi. No doubt, physical fitness is important, but mental fitness is equally, or I would say it's more important. Academic stress in tribal health refers to the heightened pressure experienced by the students, and that is mostly because of causes like language barriers, cultural differences, or socioeconomic disadvantages and limited access to the quality education. Now, it is stated that 50% of mental health conditions begins by the age of 14, and which increase to 75% whenever a child reaches the age of 24 years. So, as the need suggests, a study was planned with the objective to conduct the study on Prakriti-based academic stress of school children. They were assessed on genetic constitution. As we all know, the response of an individual to any stress differs from one to another. The second objective of my study was to study the anti-stress effect of ashwagandha granules, which is a polyherbal composition or compound, I would say. And it contains ashwagandha, brahmi, shankapushpi, vacha, and jatamansi. These are the 5 ingredients of this compound. 153 children, they were selected for the study. A survey study was initially conducted on 595 children with a rapid assessment proforma was prepared on the basis of AASC proforma. 15 to 16 years of either sex of Amravati region were selected, and out of them, 77 students they were involved in Group A and 76 students from Group B. Excluding those 19 dropouts, the results were derived on 68 students of trial Group A and 66 students of Group B. Group A, that was a trial group which received ashwagandha granules along with psychotherapy, whereas Group B received the placebo along with psychotherapy. And in present study, AASC, Academic Anxiety Stress Scale for children was applied, which is meant for 13 to 16 years of age group children. And the scale itself consists of 20 questions, which was converted to the vernacular language so as to make it understandable to the children. The drug dose was kept as 200 milligram per kg body weight, which was given in divided doses 2 times a day. Trial period was for 3 months, and the form of drug was granules given along with milk. Control drug was kept with a placebo, where it was prepared from sugar with the same color and texture. As I mentioned earlier, that a survey study was conducted initially, which included 595 children. The total 14 schools of Amravati region, they were selected for the study, and they were taken from 4 different zones of Amravati region. And then a random sampling was conducted, and the students from government or government aided schools, they were recruited in the trial, and then which gives us a percentage, because when I have seen the percentage of academic stress in Amravati region, I didn't found it, so I tried to derive a prevalence rate, and it came to be 87.98. So it is almost all 88% of students, they were in some sort of state. I won't say it was a severe form of stress, it was some sort of stress. Coming to the first objective of my research work, which states the Prakriti based academic stress of children, wherein you can see that the Vata dominant individuals or children, Vata Kapha and Vata Pitta, including Vata, they were more susceptible for the stress, and Kapha dominant or Kapha Prakriti individuals, they were least susceptible for the stress. Similarly, when I have studied for the psychic constitution, that is Manasik Prakriti, I have found that Rajasic individuals, they were in 82.35%, as you can see, and least were Sattvic individuals. There are 3 categories of Manasik Prakriti in Ayurveda, which states Sattva, Raja, and Tama. So the Rajasic Prakriti is more dominant in Vata Prakriti individuals, and that's why the psychic Prakriti individuals of Rajasic, they were suffering more from academic stress. The whole study is conducted. I have mentioned here only the part of my result, because of a lack of number of slides, they would have increased unnecessarily. So AASC score I am presenting here in front of you all, that in Group A the score, the mean rank was derived, which was 97.96 in Group A, whereas it was in 36.11 in Group B, which states that the mean rank value was higher in Group A as compared to the Group B, stating the outcome of Group A are better, and that was statistically significant. As you can see, the p-value was less than 0.05. Overall estimation of trial compound was also derived in the form of analysis, where the students whose results were compared before and after the exam, and which states that almost 97% of the Group A students has estimated mild to very good improvement, and as opposed to the almost 69% mild to very good improvement as evident in Group A and Group B respectively, thus stating the Group A has higher outcome as opposed to Group B. The very, I would say, concise form of discussion I am presenting here, which states that all the drugs are having anti-stress effect. So, in nutshell, concluding my topic, it states that academic stress is highly prevalent among children, especially 15 to 16 years of age group, that my population was taken. Vata and Pitta dominant Prakriti students, along with the Rajasic and Tamasic Prakriti, were more prone or more susceptible for academic stress. And it was found that ashwagandha granules has manifested statistically significant effect and was well tolerated by the school children with no adverse effect reported. So thank you.
Any question from the audience, please?
Was it an open study or blind study?
It was a blind study, randomized
Blind or
controlled,
double blind?
double blind study.
Are you chosen that these only 15 to 16 only?
Yes. Thank you, sir, for the question. I was about to tell this, because this is the age group where children, they start their SSC, and this is the area where stress comes in their mind. Because till the age of 9, as a parent, they don't have any, I would say, any worry about the child. But as soon as the child enters into the 10th standard, the parent, the peer, the relatives, everybody is forcing the child into the stress. That's why I have selected that particular point where stress is induced for the first time, as per my knowledge. It may happen that nowadays the stress starts from nursery itself. But
Home itself.
but the SSC student, they are more. That was the more perfect area for me to study because the compliance of individuals are also needed. Yes, sir.
How do we classify the students as per one, as per a strategic governing subject?
So there is one pro pharma in Ayurveda which gives us those type of individuals. On the basis of the questions, we can identify those individuals.
But as per my knowledge, it is little bit difficult to categorize children compared to adults.
Sir, we have a study also which have categorized babies, newborn babies in the Prakriti analysis. Because everybody has mental makeup and physical makeup also. So you can, yes, it is difficult. As per your question, yes, it is difficult, but everything that is difficult has to be tried.
Yes, yes. But the results you get, they are up to the mark or they are mixed results.
So I would say that the results are extraordinary, but this is some sort of, I would say, the initiative where we have started academic stress to be studied because most of the time physical elements are taken into consideration.
I was about to focus on Nadi Pariksha or something.
No. I haven't focused on Nadi Pariksha because it was not feasible for me to conduct it in children.
I request only
Thank you, thank
two
you.
questions per person, please, not more than that.
Sir, will you allocate the participant? How you have done that?
That was randomization. With the
If it is done on randomization, how can you say that they, according to Prakriti, they are categorized? If they are randomly done?
Every the child will come to me, that was allocated randomly into the either group. And then its Prakriti analysis or everything that was in the pro pharma was examined.
Shankapushpi brand has same content, na? Badrinath Shankapushpi.
So I won't
Yes.
comment on it because that's a different part. But these are the 5 herbal components that I have taken into the consideration. It may happen that Shankapushpi is only one drug. Only one drug.
The brand name is like that, but the content means.
So I don't think the Vaidyanath's brand is not having that brand name.
So just one clarification.
Yes.
From where you source the granules?
Yes, I have prepared those in our Rasashala.
Your own.
Yeah, yes, we are having standardized Rasashala in
And
our
the second
institute,
thing-
and that was analyzed in Government Pharmacy Institute, which is in Amravati. So we have analyzed those granules. Those all the herbal drugs they were also analyzed for their what I would say purity. And before the combination and after combination also analytical studies done. I have not presented here the standardization of
And then did you took consent from the children?
yes, children and
consent
their
also.
parents also,
And consent
and
also.
consent from teachers also, and consent from video of our Amravati was also sought for this particular work.
One last question.
Yes.
You told that you have used the translated version.
Yes.
So was back translation also done?
What?
Was back translation of your questionnaire, whatever questions you have posed, was it done before? Back translation.
I didn't got your question.
See, you have translated from English to Marathi.
Yes.
Right.
I have validated it. I have given it to our.
I agree. My
Yes.
simple question is, suppose you have converted from English to Marathi.
Yes,
Again, was it back translated to English and checked whether the
Yes,
same
it is-
mean?
This is an excellent suggestion, sir. I was not going to again make it.
For translation of education.
Right,
You should have
fine.
already-
We just wanted to know if you can do that, it would be nice.
Yes,
Thank you.
thank you, sir. Thank you for that.
Thank you, sir. Moving ahead, we have next presentation from Dr. Kriti. She will be presenting on comparative analysis of all the screening methods to diagnose sickle cell disease among children of tribal region. Kriti, please surrender.
Good afternoon, everyone. Myself, Dr. Kirti Vardeshan. I'm Associate Professor Pathology, JNC Infection, NHS Nation. As we all know, the aim of my study, as I have already declared, it is comparative analysis of all the screening methods of sickle cell disease among the children of tribal region in Maharashtra. As we all know, The screening tests which are available for us are solubility test, sickling test, peripheral blood smear, and rapid sickle cell kit test. So now our aim is to study the reliability of all the screening tests for the screening of sickle cell disease in the age group of 12 to 16 years. Our aim is to study the sensitivity specificity of these tests, to compare the results of these tests, and to confirm all the screening test results by capillary HB electrophoresis. That's a gold standard test, and to determine the topographic distribution of sickle cell disease in the study population. Ours is the prospective study with cross-sectional and descriptive. Duration was 3rd October to 10th December 2024. We had sample size of 1,502 children from 12 to 16 years age group. We have selected 28 villages, tribal villages, randomly from 14 PSCs and 7 blocks of Nashik district. We have conducted the mass camps in Zilla Vashi schools in tribal villages and collected the sample in immediate tubes for the test. We have included only 12 to 16 years age group children, sickle cell anemia, sickle cell trait, double heterozygous condition like sickle thalassemia, sickle C disease, sickle B disease, which are diagnosed only during the study are included, while previously diagnosed cases of sickle cell disease are excluded if consent is not given by the patient. Abnormal hemoglobinopathies and other rare double heterozygous condition are omitted. Methodology. As we know, solubility test is based upon the difference between the solubility of HBS and HBA. With the help of sodium hydrosulfide, the HBS is getting precipitated in the reaction mixture, and if we cannot see the black lines in the background, it is considered as a positive test. This test has been included in National Sickle Elimination Program, and that's the only test in the elimination program as a screening test. Now, sickling test, it is based upon the RBCs. When exposed to the low oxygen level, they get sicker with the help of 2% sodium metabisulfate solution. And we can see the faintly sickered RBC under the microscope. These results are observed from half an hour to 24 hours. Next is rapid sickle cell blood test. Its principle is rapid flow chromatographic immunoassay. So it comes with a buffer solution in which we have to add 10 microliter of blood, and this solution then added to acid, and the results are read like this. If we have these 3 bands of control, HBA and HBS, then it's a sickle cell trait. And if we see 2 bands with like control and HBS, then it's a sickle cell anemia, and there is no HBA band. We have studied the peripheral smear with reversible and irreversible sickle RBC morphology. At least 5 to 10% of sickle RBC should be seen to call it as positive. As we can see, this is the irreversible form of sickle RBC, and these are the reversible form of sickle RBCs. Lastly, the gold standard capillary electrophoresis, on principle of which is based upon the separation of HB hemoglobin molecule in alkaline buffer. It is a quantitative test. We have conducted this test to all the samples irrespective of the screening test results. So depending upon the quantity of HB types, we divided these into the following categories. This is the normal graph versus the sickle cell anemia graph showing the HBS zone results. The age-wise, we have found more cases in the 12-year age group, slight female preponderance. Clockwise, we had more cases in the pate and propagation. CPC parameter mean was near within normal range. So solubility test, we got more false positive cases. Peripheral smear got more false negative cases, while rapid sickle test showed a higher 2 positive and 2 negative cases. If you see the cost per test, it is high for the rapid sickle test kit. Sensitivity specificity is highest for the rapid sickle test kit with urine index as 99, which is quite good index, followed by the solubility kit. We got 84 patients of sickle cell trait, 3 patients of sickle cell anemia, and 1 patient of sickle beta thalassemia trait. So in conclusion, rapid sickle test kit is more sensitive and specific test. It is simple, user-friendly, no instrumentation and no refrigeration required. It has an additional advantage that we get the genetic pattern of the patient within a short time. we can record this test cassette for few days. Solubility test is also an accurate, less expensive, but it's also a good measure for the mass screening, but it has observation and technical bias. Positive solubility test doesn't give us genetic status of the patient. Storage of the stock region is also a challenge in a travel region. Peripheral smear and sibling tests are less preferred option as a standalone test because of their low sensitivity and specificity. Hence, rapid sickle test is the most recommended screening test, especially for the mass screening, to reduce the number of sickle cell disease patients who otherwise remain undiagnosed. In addition, it can be included in routine antenatal screening and newborn screening. Thank you, Dr. Suhas Patil sir, and respected DC madam for allowing me to do this project under the reform last year. Thank you.
The floor is open for the question.
Ma'am, could you tell us about the brand of the rapid test kit and especially the one that's used for screening in the morning sessions? We saw that different states at different levels of sickle cell screening. A little bit about that, if possible. If that also matters within the sensitivity and specificity.
Yes, sir. First of all, the principle is lateral flow chromatography. If the kit is using that principle, then it is a quite a good in sensitivity and specificity. We are using Trimitron company kit, which is recently has been supplied on trial basis in government. Even the solubility kit also we have using in government supply. So whatever, it is just the cross-sectional study. Whatever is going on under the system, we are just going in the field and studying whether how much we are missing the cases of sickle cell anemia. As you can see, there is complete blinding of the cases. I was not biased to select the cases. The children were normally going healthy school children, which were as good as normal like last year. They are not having any symptoms. These children I have selected, and through which we have got these many cases. So imagine how many cases we are missing just because of not using the proper screening test.
What is the cost of their treatment?
As per NHM, can hemoglobin electrophoresis be used as the gold standard to, compare?
Ma'am, first of all, if you see the feasibility, any test if you want to conduct, it should be feasible at the travel visa. Because there are lots of problems for transportation, for conducting the test at the field level, where we don't have skilled workers or expertise we don't have. So, HD electrophoresis, first of all, it's a costly test. It requires proper centralized lab with proper control running in the lab and proper pathologist and technician. So this setup is not possible at the time. So there is a centralized laboratory which are already functional in the state, to which these samples are being transferred. But let me tell you, in this project, lots of samples I have to omit because the sample was plotted while it was going to the peripheral lab for confirmation test. Many times the repeat sampling is a headache because to punish the child again, to parent again for the resampling is also a great job to do.
Every taluka patient there is a electrophoresis procedure. Available in the tribals also are.
So there is one mini machine has come, HB electrophoresis, but again there is electric supply is required and instrumentation is required.
Most of the taluka level has electric.
Yes, sir,
In the
but,
system already they have produced the electrophoresis that we can use under the NHS.
sir, I have gone to very top mountains in Ambakeshwar where literally it's not possible to even to bring that sample within the time to the lab. Yeah. So my motto is why this sickle kit is important because we can get the genetic status of the patient at a time and we can categorize the patient and send it to the tertiary level and channelize that patient, the counsel and screen the family of the patient and we easily catch up those patients because it's increasing in very fast way.
Ma'am, just one last question, just to clarify this. The testing kit that you had compared is not the government supply testing kit, right?
It is.
It is.
Yes.
Thank you.
Ma'am, and what about the missing cases of the combination of sickle, thal, which we tend to miss with the solubility and the because we are giving a genetic diagnosis to the patient. But suppose there is a combination of sickle thal or sickle with some other entity. What is your take on that?
See, ma'am, this solubility, as I already told you, it doesn't give you genetic status of the patient. But with this kit, even the 10% of the HbS is there. When there is a combination of double heterozygosity, the HbS percentage will become less. That's the thing. And maybe the other, like HbC will be more, HbS will be more. But with this kit, even the 10% HbS you can detect, at least you know that there is a sickle patient.
So with this, we don't have to do hemoglobin electrophoresis
No,
at
you
all.
have to. It's a screening method now. You have to do confirmation test because it will just give you a clue. But that clue is very important because we are missing that patient in the society.
So it is, what is the translational value of your study?
As in one translation.
Value, it is a point of care device you are taking.
Yes, point of care. I want, like, we are projecting this for the policy change for the national immunization program. That this solubility test, although it is a good, what I observe, this kit, when it is in the government supply, it is a 25 test kit. You have to create the 25 test kit stock reagent. You have to store in the fridge. And the validity of that reagent also goes. If there is a two patient in the OPD, you cannot screen those patients. But this kit, it is easily transported. No refrigeration is required. Even a single patient you can do with a finger.
It is a sort of a point of care
Yeah.
device. That is
Yes, it will solve many problems.
But if you are including it.
One last question, madam wants to ask.
I had a question. Yes, ma'am. It's following my colleague's question. I had a question following my colleague's question. You said that this was just a cross-sectional study. Do you think this has direct translational value, or do you think we need to do more studies?
I am going to plan for the further study on from the newborn to the ANC and adult to the adulthood. So how much effective is this kit even in the newborn? That is our next upcoming project. Like there are challenges to collect the newborn sampling. We are working on over it. How we can overcome the challenges to proceed with the practicing this kit.
Ma'am, I must add to this because you have mentioned it. I am Professor Pediatrics. I was at Dhulia Medical College, and we have an ongoing study with the Center of Molecular Biology at Hyderabad, Dr. Giriraj Chanda, who has developed this kit, the kit you're talking about, and we are all at the present moment we are utilizing it for newborn screening, and we are getting very much concordant results.
Very nice, ma'am. That's good to hear.
Have the next presentation, please. Thank you.
Moving ahead, we have Dr. Saroj. He will be presenting on health and life challenges of pregnant adolescent girls in tribal district, a comprehensive study.
Good afternoon all. Myself Dr. Saroj Kutri. I'm working in Gadchiroli as a district program manager Ayush. My study topic is health and life challenges of pregnant adolescent girls in tribal district Gadchiroli. Adolescent pregnancy means 18 or below 18. Adolescent pregnancy is a significant concern in tribal district like Gadchiroli, posing unique challenges due to socio-economic vulnerabilities and cultural practice. Socio-economic vulnerabilities means they have limited sources of they don't have like industrial area and education, health education and education means they have poverty and lack of knowledge of reproductive system. So that's the cultural norms and contribute to early marriage and subsequent pregnancies, amplifying health risks for those young mothers and their newborns. These risks involve malnutrition, anemia, higher chances of childbirth, complications, and societal stigma. The comprehensive study focuses on the specific health and the challenges faced by pregnant adolescent girls in Gadchiroli district, aiming to generate evidence-based recommendation for policy and healthcare interventions. My objective is identify the health challenges. The study will explore into health challenges specific to pregnant adolescent girls, including nutritional deficiency like anemia and protein and energy malnutrition, and identify gaps in the access to proper maternal care. Proper effective strategies. Propose effective strategies. Based on the study finding, the research will propose evidence-based strategies to improve healthcare access and community support for vulnerable group, particularly pregnant adolescent girls. Examine contributing factors. The research will explore the complex interplay to socio-cultural and economic factors that contribute to the prevalence of adolescent pregnancy in the Gadchiroli district. For that, the study design is mixed. That is qualitative component and the quantitative component. Uh, quanti- uh, Quantitative component, a cross-sectional survey will be conducted to gather quantitative data on health indicator, nutritional status, and access to antenatal care. The survey will be standardized questionnaire and tools to gather information for reproductive respective sample of pregnant adolescent girls. And the qualitative components, in-depth interviews and the focus group discussion will help the adolescent girl, their families and healthcare providers and community leaders to gain qualitative insight into the socio-cultural content surrounding adolescent pregnancies. And data analysis is the both qualitative and quantitative data. Expected outcome, high prevalence of challenges. The study expect to find high rates of malnutrition and anemia among pregnant adolescent girls in the Gadchiroli district. Socio-cultural factors is the study aims to identify socio-cultural factors such as early marriage, limited access to education, and lack of awareness about reproductive health as major contribution to adolescent pregnancies. Inadequate maternal care and recommendation for safety. My conclusion is comprehensive intervention, improve healthcare access, raise community awareness, and engage socio-cultural stakeholders. Thank you.
Any questions, please?
And it is your study in the 18 and below 18.
Yes, sir.
You may have there is a Gadchiroli district has a early marriage.
Yes, sir.
16 to 17.
Yes, sir. That statement is called Ghargushi Paddhat. In some caste, that Gond, Pradhan, and Madhya Samaj, they used to marriage in early age. Not marriage means they have the concept that girls used to leave boy home, and they get if they get pregnant, and then after they marriage.
Now, what is your study period, madam?
So it is compulsory studies.
When you did this study, or it is completed? Now, today also, the such Ghargushi program are some these traditions also going there in the Gadchiroli district.
Some area, sir, some area in Mulchera and Kochi area, not whole Gadchiroli district.
Previously it was there with the 10 to 20 years back, but now this now most it is reached to the 0%. 18 and 18 below, it is not now there.
Sir, till today, means in this year, 300 girls are below 18 are pregnant.
Worked there as a medical officer while in 2020, 2000 to 2013. And I was there as a class 1 physician. I worked there. At that time, there was some percentage was there, but now you have to narrate these. These are women the 18 and below 18. Now today is not so much problem.
300. Any other questions?
What are the main findings of your study? What are your challenges?
Sorry, ma'am.
Main findings of your study. What are your challenges?
My challenges are girls are not that much friendly to discuss this topic, and they are not regularly visited PSCs, so we can't control this.
So, what recommendation you are giving based on your
The recommendation is we have to increase IEC material, and we have to increase peer graded supporter and Maitri clinic regularly.
Was there one question. Was there any cultural aspect to the early childbirth or the reproductive problems that these girls faces?
Was there any cultural aspects that you found out, like the tradition, like in Jharkhand, the whole tribe?
Yes, sir. In some culture, they used to marriage early, like I said, Gondi and Madi and Pradhan Samaj. But not now. Now they educated. But before that, they used to get married.
Ma'am, is there any medical legal consideration on this aspect?
Yes, ma'am. Yes, ma'am. We have district advocate and they consult. Thank you.
One last question here, please, madam. See, there's a lot, as madam has already pointed out, it's a medical legal constraints. If, and already sir has worked in such places, if something like that is happening, if you're still having the data, please share it in a proper forum so that the things can be taken care of in future. Thank you.
Thanks.
Moving ahead, we have Dr. Maheshwaran. He will be presenting on morbidity profile among tribal ashram school children in Palghar district, Maharashtra. Doctor, you have 7%.
Good afternoon, respected delegates present here. So I am Dr. Maheshwaran, representing SafeGS Medical College, KM Hospital, Mumbai. Currently, I am working as an assistant professor at IIT. So I will be presenting my study regarding the morbidity profile among tribal ashram school students in Palghar district of Maharashtra. So before starting my study, I would like to say this study was a part of actually Gandhi Medical Fellowship. Gandhi Medical Fellowship was nothing but a fellowship which is given to the interns by a memorandum of understanding between KM Hospital and Piramal Foundation in Mumbai. So the main objective of this Gandhi Medical Fellowship is to give community exposure to the intern students. So as a part of it, we took 25 intern students from our hospital and we took them to 4 tribal villages in the Palghar district, Maharashtra, namely Bidwal, Kurunze, Ambiste, and Dekari. So students were given many sort of exposure like engaging with the community tribal healers, engaging with the community as a whole, and visiting Anganwadis, visiting primary health centers, and understanding the basic health and infrastructure and their needs of the underprivileged tribal population. So this was a camp-based approach mainly we conducted in 2 villages. So as we all know, the ashram schools from the Indian tradition we can say are a part of a school community where students engage with each other with professional teachers for their development. So it was considered as a direct intervention to address social inequality in the education. And the key focus of these ashram schools was to safeguard children from poverty, illiteracy, addiction, and provide a conducive environment for their learning. So despite there are many guidelines emphasizing the importance of health of school children in the tribal areas, they somehow are disregarded in practice as we noticed. And also ashram school children, as we observed, live in very precarious conditions due to which they face many physical, psychological, and social problems. So improper sanitation and structural incapability of these infrastructure institutions lead to further harm. So nutrition deficiencies, disease, and other psychological problems in childhood can also ruin their entire adult life. So given that these children spend most of their time in the residential setting, ensuring that their health and safety becomes the primary safety becomes an important structure not only of the education institution but also of the government bodies and the public health department. So our objectives were to assess the gender health status of the school children in the 2 villages, then to assess the nutrition status among these 2 children, and to provide suitable recommendations based on our study findings. So we conducted a comprehensive health camp, which was conducted during the month of July 2024 by a team of faculties and interns from SafeGS Medical College. As I said, at 2 ashram schools we conducted, one from Bilmal and another from Kurunse. So school participants were actually gathered by the school authorities, and the school principal granted permission on assisting in gathering students to participate in our health camp. A standardized tool which we use for documenting the health issues among the students was used as a screening procedure. Then for the nutrition status, we assessed using the BMI for age criteria, which is body mass index. And for the refractive error, was assessed using the channel chart for all the children. And the hemoglobin status was assessed using a digital hemoglobinometer. And the main priority was given here only to the adolescent girls, as we observed from our finding from our previous interaction, like adolescent girls are more vulnerable to anemia. So we wanted to estimate. So as far as results are concerned, the total number of students participated in our camp was 457, and the mean age was 12.23 with a standard deviation of 3.5. The range was 13 years. So as far as gender distribution is concerned, majority were girls, which accounting to 68%, and 32% were boys. So according to our first result, which is BMI for age, we can see 78% were underweight. So now I need to quote one thing. We could able to trace this BMI for age for only 252 children out of the 457 due to some resource constraints. And also as far as the refractive error is concerned, we could able to screen for refractive error only for 108 children, out of which we found 67 children were negative and 32% were positive. So and also as far as the anemia is concerned, using digital hemoglobinometer for 198 adolescent girls, 99% were anemia, which was very astonishing for us. And we classified them according to WHO criteria for mild, moderate, and severe anemia. And we could see most of the adolescent girls fell in the category of 89.29%, which is moderate anemia, and 10 girls were amounting to severe anemia. So as far as our health screening is concerned, majority of the students suffered from acute respiratory infections, followed by acute febrile illness. Since it was conducted in the month of July, we could see more cases of acute febrile illness and acute respiratory infection as their common morbidity. And also, as a part of our health checkup, we also checked for the worm infestation status. Almost all children have their history of worm infestation during their past 3 months, so we should help and also tablets for the same. We also conducted some health talks to adolescent girls regarding menstrual hygiene and also to boys regarding the reproductive changes during the adolescence. But results were not that much satisfactory. Students were not that much aware of what is happening during their puberty development. And also, general sanitary conditions of the school was also examined, but results were not that much satisfactory. The infrastructure and as far as the general sanitation with regard to toiletry facilities were not that much high, properly maintained in the school. So as a sort of conclusion, I could say the students suffered from undernutrition, refractive errors, and anemia. So health protection of children becomes a priority, and it's absolutely critical here. And as a part of the recommendations of our study, I would like to give nutrition interventions enriching the daily diet in the ashram schools, which is provided by the kitchen there, and also regular deworming, adequate environmental sanitation needs to be ensured, and existing health programs mainly RPS scheme, Rashtriya Bal Suraksha कार्यक्रम, and weekly iron and folic supplementation program, and Rashtriya Kishori Swasthya कार्यक्रम, especially for adolescent population, need to be proactively implemented for early diagnosis of the health issues. So proper coordination between tribal, education, and also public health bodies is essential for healthy growth and development of the ashram school students. So I'd like to end my presentation here. Thank you very much for the opportunity, and I would like to express my gratitude for my Professor Dr. Srikalan for giving me the opportunity to present. Thank you.
Any questions from
How
the
the
audience? Please? Yeah.
How the sample size was estimated and from whom the consent was taken?
Actually, sample size was not estimated since it's a camp-based approach. No? We personally approached the school health authorities, which is the headmaster of the school. We took, even though we visited 4 villages, no? We took 2 villages, Rimal and Kurutse, and we approached the health master, this is the headmaster for the health camp, and he helped in gathering the participants. So for all the children, consent was mainly given by the student health headmaster, and for adolescent girls, mainly assent was taken for the hemoglobin estimation.
So, so you found significant number of students with anemia, with malnutrition, and with refractive errors. But the only intervention you all did was to give deworming tablets. How ethical do you think it is to screen people for certain illnesses, but not be able to ensure at a certain level that you're actually working towards getting them to get better? This is the first question. And second thing is, the slide about why ashram schools exist is for the socio-economic betterment of Adivasi students. And I'm wondering, I mean, why then in your recommendations you don't have anything about, the school itself? Obviously, being in the school is what is making the kids have these problems, where they're not being recognized. So, can you please comment on this?
Sure, sir. So first answering to your first question, sir. So we have screened these many students as a part of our camp approach. The main agenda of our Gandhi Medical Fellowship was to give primary community exposure to our interns, mainly during the internship period. So since we found based on our interaction like these many problems are prevailing in the community, we thought of taking it as a camp approach, and we found the following findings. So as a follow, we have insisted with the school headmaster, we have shared the data with them, and also the respective attached PHCs with these 2 villages, Bengal and Kurutse. We have also shared the data with them. So we have requested the health department and the medical officer of the PHC to arrange for further camps there. And those children who have found positive for refractive error and also for the other ailments, we have referred those students to the nearby attached PHC, and proper interventions have been given to them. I didn't mention it in the slide since I was only presenting regarding the findings of our camp. But this follow-up was ensured. And also this Gandhi Medical Fellowship is going to be leveraged year-wise with understanding with memorandum with the Piramal Foundation. So we are going to leverage this camp more in the coming years, and every year we'll be conducting camp in these underprivileged areas of further study. And to the second question, Ashram School. So mainly in Maharashtra, especially in Palghar district, this Ashram School is run mainly by the tribal department of the state of Maharashtra. So to the health authorities and to the Gram Panchayat Sarpanch, we have discussed this issue, like the regarding the sanitary conditions, regarding the proper infrastructure of the ashram schools, and they have proposed to the government for upgrading those facilities. We have had those preliminary interaction. Maybe in coming years, we will present those things also. So, yeah.
Am I allowed to ask a question?
Please.
I have a question following
Yes.
this around the ethics of what you're doing. So I'll just repeat that after that. I was wondering, and actually this is a question for the other students, have you ever presented your findings back to the community?
We haven't presented to the committee, but we have shared the results and our Excel sheet, all our data with the headmaster of the school. Actually. So he was supposed to take the action, and also we have also informed our findings to the nearby PHCs, primary health centers, and medical officers will be providing the further intervention for this. Mainly, our fellowship was only for a 1 week duration, just to give a community exposure to the students. So by chance, we took this camp, we got these findings, so we are in the process of leveraging it further. So as a preliminary step, we have informed them, and interventions have also been provided for the children, and we'll be doing follow-ups later. Yeah. So every year it will be conducting through a campus.
May I just add
Yes.
one last? Now, I think the essence of this presentation.
Yes.
Your presentation is very good, but the only thing is that this is the data which
Yes.
you are presenting. So do you think that the permission, whether it would have been ethical to present this data on the behalf of the school? Have you informed them that you will be presenting this data to this August presentation? Before
Sorry.
this community?
Sorry.
Do
We
you think
haven't
this is
informed.
ethical?
Maybe you can involve some ethical, but we haven't informed. Sorry. We haven't
One last question from here, and then we wind up your session. My question to you is, when you talk about the, when I have some silence, please. My question to you is, you are talking about the nutrition. Nowadays, the government of India is providing the nutrition at all the schools. So it is thoroughly cross-checked before it is being implemented. That is number one. And number two is, one such findings you are giving and you are telling that the food or whatever they're having, the living conditions are not good and it is creating deworming, then why the parents are still leaving the children there? These are the two major concerns, I think, which has to be looked at.
Yes. So we have also tried to trace the reasons for that. Sir. So as we found out from the headmaster, like many of the students who are staying in the Palghar, the Bimbal and Kurunjay schools, most of their parents are migrant laborers and they work in Ahmedabad, Gujarat and many such areas. They leave their children in the tribal school and they go off. Sir. So we are also, even the school administration is finding very difficult to establish contact with the parents and for further follow-up and tracing. Sir. So that may be one reason. Sir.
Just one
Yes.
comment. You said the study was conducted in July.
Yes, sir.
That is the time when you people take out the interns, right?
Yes, sir. Yeah,
So
it
that
was a
is-
1 week follow-up.
Yeah,
Yes.
so that happens every year in July.
This was our first project, sir, with the pyramid. This was the first batch.
Because the kind of morbidity you are showing is attributed to this is
Yes, sir, seasonally. That's what I told, sir. Like this is the first batch that we are having. So in the further coming years, we are going to leverage this.
Unless
Yes, sir.
you expand the sample size.
Yes, sir. Yes, true,
in a
sir.
more scientific way,
True, sir. Yeah.
the results will not be much.
Yes, sir. We'll make sure of it in the next. Yeah, sure. Thank you. Yeah. Thank you for the opportunity.
Thank you, Dr. Mansur. Moving ahead to the next presentation from Dr. Akshay Doble. He will be presenting on holistic intervention strategy for tobacco cessation in tribal communities. It's 7+3.
Respected chairpersons, distinguished guests, this study, Holistic Intervention Strategies for Tobacco Cessation in Tribal Community, was a part of a larger cohort under the jurisdiction of Additional Tribal Commissioner Thakre sir, wherein the ashram schools were examined for oral health status and tobacco-related diseases. Holistic health, as we all know, offers an abundance of non-toxic, affordable approaches from herbal remedies and nutrition supplements to massage, acupuncture, yoga, detoxification, changes in lifestyle, environment, meditation, and many more that attempt to restore balance and harmony in the body. It is said that 3 to 4% only patients are able to successfully quit without any help, and 6 to 8% need counseling and behavioral modification. But more than 30% require pharmacotherapy for intervention and quit rate increase. So we need the need of the study was that several studies have disputed the efficacy beyond the placebo effect of the holistic medicine in treating any known diseases. They say that all the holistic medicine offered are giving placebo effect. Used only in conjunction with conventional medicine and not as a replacement therapy. So our aim was to evaluate the effectiveness of a holistic approach to tobacco cessation amongst tribal population of Nagpur division, focusing on improving the health outcomes. Sample was estimated by the given formula and 50 participants each were taken. It was a randomized controlled trial at a dental hospital. Participants, 100 tobacco users were used. I think this is a different presentation.
Sorry for the technical glitch. I think we will take the previous presentation which we have
Number
missed.
10 it was labeled.
Yeah, sir, you can do one thing. You can check your presentation with the AV team once, and we, in the meantime, we will take Dr. Meghna's presentation.
What they have
If that's
considered, I
okay.
think whatever is being sent already.
Yeah.
Yeah, this is there. Can I continue? He has uploaded to the right one now. Can I continue, sir?
Yeah, you can continue. No
So
problem. Okay, there's a problem. 1 second, sir. There's a problem in keeping the time.
Yeah, that there will be.
Okay,
Now.
then what we do is,
I
sir,
quickly finish.
no, sir,
No,
it's not,
sir,
sir,
it's
please, it is not about that. Please, my sincere request is let the participant, we can come back again. Please.
Sure.
Yeah,
Thank
so you just cross-verify
Yeah,
everything
cross-verify
once and
then.
you are sure with your
This is
presentation.
the right one.
No, I do understand,
We
sir, please.
understand that.
Please,
Then
please.
you have exactly 7 minutes from beginning.
Yeah.
Yeah. From beginning, please do. Third वाला presentation अभी लगा दीजिए. Dr. Meghna Chandrachud.
Good afternoon to everybody once again. Really sorry about the small technical glitch. I would like to reintroduce my topic. I'm Dr. Meghna Chandrachud. I'm a faculty in the Comprehensive Cleft Center at the Department of OMFS, MGM Dental College and Hospital. And I would like to bring draw attention to the voice of caregivers for the perspective of cleft lip and palate surgery outcomes in the tribal communities that we have operated at our center. And as we all already been exposed to the quantum of tribal communities that are present in India, according to the older census, there is about approximately 8.6% of tribal communities in India, of which 9.35 are in Maharashtra alone. That is amounts to 10.5 million of the population. And due to poverty, social stigma, inaccessibility to medical care, and lower literacy rates amongst this population, it is and the exact prevalence of this defect, that is the cleft lip and palate defect, is not known to us. There is a study that was a demographic profile of the pattern of cleft lip and palate in a 15-year experience of a Varda institute, where they have come up with this reasons that could have led to this demographic profile among the cleft lip and palate patients. And to collect the prevalence is the only way to do that is by performing hospital-based surveys. Moving ahead to the challenges that usually are faced in the tribal population is that they do not have a proper access to maternal care, pre-maternal medications, prenatal care, postnatal education and awareness about the defect and the course of treatment that would be required for the defect. India sees an estimated rate of amount of approximately 35 to 40,000 new cases of cleft lip and palate. Here is a small brief of the treatment protocol that many patients are not often aware would follow a patient that is a mild to moderate or severe or form of cleft defect. So initial starting right from first birth to the first month of the child's birth, there's an initial assessment and an option of a pre-surgical orthopedic treatment that is called as a nasoalveolar molding that could be provided if the child is brought to us within 45 days of birth. Following which 3 to 6 months is an appropriate time for a lip repair and 9 to 18 months an appropriate time for the palate repair. Speech assessment, which should be preferably followed when the child begins to speak after the age of 3 years, followed by intervention with orthodontic and correction of malaligned teeth, expansion of the palatal bone, and alveolar bone grafting for correct eruption of teeth, followed by aesthetic corrections at the age of 12 to 16 years with definitive orthodontics and orthognathic, that is jaw surgery and rhinoplasty. A long list of series follow for the proper social development of the child apart from the functional and aesthetic component. And so the rationale of our study is to understand the perception of the impact that a treatment will bring into the life of a cleft child, and understanding the problem areas in the tribal area, a tribal background, whether they understand the understand the need for the increasing the awareness among the tribal population for a better quality of life and better outcome. The objective was to study evaluate the caregiver reported outcome among the tribal patients, because these children are obviously of the younger age group where their outcome cannot be directly and be taken for the word. The caregiver of the child was taken up for this questionnaire, where the child was evaluated for caregiver evaluated about their opinion post surgery for lips and lip scar appearance, nose nostril appearance, speech distress, speech function, and the social function of the child. The main objective was to underline the impact of age at which the surgical repair should have been conducted, for which we had taken 460 participants. It was a cross-sectional questionnaire study. 460 participants of at a mega follow-up camp conducted at our institute every year, of which the cleft lip patients, 223 in number. They were divided into two groups A and B. A group was where the lip repair was done before 6 months of age, and the group B was after 6 months of age. And cleft palate patients were 94 were in the group A, where before 18 months of age and after 18 months was group B. The questionnaire that was used to conduct this caregiver reported outcome was a licensed questionnaire from by the McMaster University and Sick Kids Hospital, the Cleft Q questionnaire. We had obtained a Hindi version for which, and now we are working on developing. The back translation has been done for the Marathi version of the same for further conducting this study in the other children as well. The parameters assessed were lip appearance, lip scar, appearance of nose and nostril, speech distress, speech function, and social function. The data obtained kiloplasty incomplete lip cleft lip children showed that the parents reported with superior lip appearance that was 10.4% greater in the group A, that was surgery was done earlier, and the nose and nostril did not show much statistical significant difference. In a unilateral complete cleft lip of one side, we observed that the lip scar score was better in group A by 5.7% and than the group B. Irrespective of the age, the nostril appearance scale did not show much change. The bilateral complete lip and palate children, for the lip surgery, they showed a statistically significant difference in the score of group A and B for lip scar, lip appearance, and nostril as well. 5.3% better than those among the children who were operated at a later stage. The nose appearance also reported 3.7% better outcomes, but at the children who were operated later. The nose appearance was noticed to be either same or better in the later operated children. In palatoplasty, we have compared 4 different severities in each of the groups, that is group A earlier operated and group B later operated. And in the severities, we have noticed that all severities have shown 8% better speech distress reduction in the group A. And in the group B, that is, in speech function group, we have obtained a better outcome of 10%, 8%, 5% in each of the severities of early operated children. 8% of the caregivers in Group B felt that their lower self-confidence, whereas only 2% in the Group A showed lower self-confidence in the social function assessment. Not statistically significant between Group A and B based on the severity of these children's cleft. The various factors can have influenced these outcomes, and there is teenage pregnancy and where we have obtained data in an adjunctive study that the average age of the mother of the children that came to us as tribal children was 19.6 and the father was 22.4, and also there was a high rate, that is almost 63.5% of consanguineous marriages, which have one of the known causative age factors for a cleft lip and palate. So the main agenda was for us to get this information of importance of age in the surgical repair across to the tribal population, that and show them that there is an improvement in the lip scar and lip appearance, and also in the voice, that is the speech and the social function. The take home message for us here is that there is a need for targeted tribal caregiver education programs for surgical intervention of this at the right age group. And also the impact on appearance and speech by an early intervention could be shown and made to them understand at a grassroots level with the help of primary health centers and ASHA workers. Enhanced efforts focused on the access to speech therapy after surgery also needs to be underlined and explained to the caregivers. Thank you.
Any questions in the audience, please?
Ma'am, what was the timing of the administration of the questionnaire after the surgery? What was the timing of administering the questions?
Ma'am, at our comprehensive cleft unit that we are conducting mega follow-up programs every year. So whenever we have each of the follow-up programs, it was a cross-sectional study. So all the children who are operated only for lip and not yet for the palate were subjected to the lip assessment scores, and children who are operated for palate were subjected to the palatal assessment, speech and social function assessment.
Yeah, but how many months or how many weeks after the surgery is my question.
Ma'am, we have not kept a track of any children that was freshly operated, that is within 6 months time. All of them were generally all after 6 months of operation.
Because that will
Impact
influence.
All the patients were after 6 months of surgery.
Anybody else? Okay, just I would like to ask you that the amount, the kind of problem which you are telling about the cleft thing. You are saying that 30,000 to 40,000 patients a year. And then when we look at the tribal population, which is nearly 9% of the India's population, I don't think so many cases will be there in the tribal category per se. So for me, like because we are in the ICMR, so probably this is not a public health issue at the moment. It can be a societal issue from the family's perspective and things like that. But in your presentation, I could not find that how a person's individuality as a tribe is going to affect this whole phenomena and his or her desire to get this thing done and feel a much better or lead a much better life in their society. So, I mean, that connectivity is something which maybe it is a bit generic in your case, maybe it can be worked upon.
So I would like to just
Sure.
add that the reason that we took up this questionnaire specifically among the tribal population is a general interaction which these patients stay with us for almost 12 years of their age. So a general interaction, we realized that the acceptance for surgery and a continued surgical intervention is more among the non-tribal compared to the tribal. So we use this protocol to show pictures and educate them about when they should be following up and how the earlier patients have shown improvement. So that is the time when we felt that the tribal aspect came into the need, and we conducted a survey specifically on it.
Last question from my side. You told that consensuous marriages in tribal is one of the cause. But if you look from the cultural point of view, because I have also worked in tribal areas, so it is not that everybody marries somebody. So there is something called a Steen Devi, Seven Devi, something like that. So according to that, the marriages are done. So they also take lot of things into picture before they're actually doing the consensual marriages. Any take on that?
Sir, I'm sorry, I was not aware of the specific detail that they follow culturally, but the data that we collected showed 63% of our patients were giving history of consanguineous marriage. So that is why I included that point.
Thank you.
Thank you. Moving ahead to the last presentation of the day, I would like to invite Dr. Akshay Dove. He will be presenting on holistic intervention strategies for tobacco cessation in tribal communities. So it's 7+3, Dr. Akshay.
Greetings once again. So as I said that this study was a part of a larger cohort wherein 32,000 school children were from the ashram schools examined for oral potentially malignant disorders related to tobacco abuse. Holistic health offers an abundance of non-toxic, affordable approaches from herbal remedies, nutritional supplements, acupuncture, yoga, detoxification, changes in lifestyle, environment, meditation, and many more attempt to restore balance and harmony in the body. It is said and documented that 3 to 4% patients only are able to quit on their own without any help, and around 6 to 8 need counseling and behavior modification. Pharmacotherapy accounts to almost 30% of patients who are able to quit in the process of quitting. So, need of the study was several studies dispute the efficacy beyond the placebo effect of holistic medicines. Holistic medicines are used only in conjunction with conventional medicine and not as a replacement. Our aim of the study was to evaluate the effectiveness of holistic approach to tobacco cessation amongst tribal population of Nagpur division, focusing on improving health outcomes. Sample size was estimated from this formula, and 50 participants each were deputed in each group. Sampling method was simple random sampling. We identified the level of addiction by Fagerstrom test for nicotine dependence and readiness to quit by trans-theoretical model of behavior change, combining both group 1 and group 2 were assigned 50 each, wherein in group 1 conventional counseling with routine pharmacotherapy was given, and group 2 conventional pharmacotherapy in addition to holistic methods were also assigned. So level of addiction was judged based on Fagerstrom test for nicotine dependence. Those who were in the score of 7 to 10, highly dependent, and those who are ready to quit, indicating that they were in the contemplation and action stage, who said that they can quit, and they were assessed. So such 50 people were, for 50 students were assigned with inclusion criteria. Only smokeless tobacco chewers were there, highly dependent and in contemplation and action phase. Exclusion: smokers were excluded, mild, moderate dependency were removed, and those who were not ready to quit, that is the pre-contemplation stage, they were also excluded from the study. So group 1, where conventional pharmacotherapy, NRTs were given. In addition, Bupron was selectively given as and when indicated. Group 2, in addition to the conventional gums and Bupron, we gave them Amla Supari. So why Amla Supari? Because Amla Supari physically mimics the kharra which they were actually using. So it mimics kharra, and many a times there is a habit of oral gratification. They need something in their oral cavity going on. So this was very close to that. In addition, we trained them for 3 minutes of deep breathing, Anulom Vilom. In addition to certain lifestyle modification like early morning, getting up in the morning, and regular food habits. So all these modification in addition to conventional pharmacotherapy were given, and for every craving they were asked to do asked to chew and asked to do pranayama for 3 minutes. So follow-up was done over a period of initially 1 week interval for 3 weeks, because they were all in contemplation stage, ready to come for counseling. Later on, for 1 month, 3 months, and 6 months. So, as we can see in this group, not much of difference was there. around out of 50, around 15 to 20 people, 20 students did not turn up at the third stage follow-up. But there was one more important factor which we tried to assess was the early morning, immediately 1 hour delay in cravings. So it is said in addiction medicine, as far as tobacco cessation is concerned, that 1 hour delay, if they are able to do, so they are able to quit faster as compared to others. So early morning delay, you can see in the third counseling session, there is a significant p-value. We can see that many students were able to delay their urges for 1 hour consistently. Then we notice the reduction in number of cravings also with holistic approach, the customized holistic approach we had. The number of students out of 50, almost 46 were able to cut down on the number of cravings throughout the day which they had. So the craving reduction or the lack of reduction factors are ease of availability, cost effectiveness, and ease of availability via parents and teachers. In this survey, we noticed that parents and teachers are the ones who initiate the habit. In conclusion, I would like to emphasize the fact that holistic approach requires intellectual, physical, emotional, and spiritual all well-being together. Holistic approach is more effective for long-term abstinence and preventing relapse. Holistic approaches should be accompanied by a professional treatment plan but can be effective well beyond the initial recovery phase. Improved success rate with holistic approach is there. As we all know that multi-pronged factors are involved in tobacco addiction, genetics, environment. So it is actually a biopsychosocial phenomena. So multiple approach strategies also should be there. As the WHO's Sustainable Development Goals are there, the first goal of poverty, no hunger, and good health. So all these four goals should be targeted, and empower, which is given the strategy for tobacco control in addition to FCTC must be implemented. The SUK, which is the goal for MUHS here, we need to target the sustainable development goal of first, second, third, A, and fourth. Upliftment by giving alternate profession to the cultivators. Knowledge, basic education needs to be improved, and there needs to be holistic approach, and healthcare via mass screening program should be also done. Thank you so much.
I need two quick questions, please, from the audience.
What drug was used in pharmacology?
Sir, pharmacology, NRT gum was used, that is nicotine replacement therapy, wherein 4 mg gums are given.
Nicotine for the de-addiction of nicotine.
Yes, sir. That is done because it is done in a supervised, customized manner.
So that is ethically not permitted.
Sir, it is given.
WHO
It is
also does
practiced.
not approve it.
It is practiced, sir. It is
Practiced,
legally.
I know. WHO does not approve.
So WHO.
And ethically, it is not proper to use nicotine for nicotine de-addiction.
It is there. It is a documented evidence that nicotine in a supervised, customized manner it is given for de-addiction.
Sir, why pranayam is selected in second group? I mean, from where you got the reference for quitting the tobacco? Pranayam is.
Yeah, sir. I will get into severe addiction and stress. So those students or those people who are severely addicted are generally under a lot of stress. And when their person is under a lot of stress, they are not able to streamline their thoughts. So in order to streamline their thoughts and customizing it to our study, the craving delay which are to be done. So mainstay of behavior therapy is to delay the urges or craving. So when a person is focusing, there is conventionally it is said 5 Ds are there: delay, drink water, deep breaths, and discuss with your fellows. So these 5 Ds are important, in which one of the D is deep breathing. So deep breathing, customizing it to pranayama, anulom vilom will streamline your thoughts and will help the patient delay their urges.
But I think, sir, for stress, you recommend Anulom Vilom Pranayam, but more convenient is Brahmari.
We'll try that also.
I think we'll take up this last question because the delegates are arriving for the program. So I think this is the last question and then we'll wind it up.
Yeah. Did you look at the confounding factors about what is the duration of addiction and whether the parents are addicted to it?
Madam, parents were also called for in the second counseling session, but it depends on when to call a parent. So only few parents turned up because it is very difficult to get the students, and getting parents are more difficult. So
The duration of addiction.
duration
Improvement outcomes.
1 year. 1 year follow-up was done.
No. In individual cases, what is the duration of addiction as against how much time they take for recovery or how much?
Ma'am, all these students were 16 to 23 years of age under the age group of 16 to 23 years of age group, and 3 to 7 years they were having this.
Sir, how did you manage to assess that the children that might have performed pranayam at their place?
Sir, these students were brought to Government Dental College Nagpur. They were brought here, they were screened there, then shortlisted. Those with oral lesions and those with oral addiction, they were brought to our college. This was done in college premises.
So you have followed it daily?
Followed it? No, sir. Every week, and then 3 months and 6 months. Once in every week they were
You have asked them to do pranayam only once in a week.
No, sir. They did it daily.
So that's why I'm asking who has
It
followed
is,
them, who has followed them that they have did it or not.
No, it is very difficult to do that. It is just self-declaration.
But if they might not have followed the pranayam, the results might vary.
Yes,
That's
definitely. Definitely. It will definitely.
It was more of an unsupervised, right?
Thank you.
Thank you, sir. Thank you, everybody. And it gives me an honor and privilege to propose the vote of thanks for this session, which is for the team 25 from the Hall A, so the Tribal Empowerment and Educational Research Award session. And first and foremost, Praveen sir and Nishan sir, thank you for they have been bestowed often the most difficult task of giving the first prize to the one of the papers, and the results will be declared or during the valedictory ceremony. So everybody has to wait to know whose is the best paper from this hall. And so let's be patient for to knowing the results. And moving ahead, so we had a lot of great discussions and academic discussions on the tribal health with the groundbreaking research and the innovative research academics which is going on in the tribal health, which will help in sustaining and promoting the tribal health. Thank you everybody to be present here and attending, giving us a full house session. Without the delegates, the sessions are not possible. And thank you to the volunteers, Dr. Ms. Ekta Chauhan, Krisha, and Bhargav and Dikshita for managing the halls pretty nicely. And last but not the least, the AV team who had been busy managing the technical part and also shooting the videos. Thank you, everybody. We will now proceed for the refreshment, followed by we will be joining at the auditorium for the inauguration program at 5 p.m. Thank you. Have a great day and have a great time at Amescam. Thank you.
चलो बंद करो कैमरा बैकअप